Welcome everybody. I'm here again to tell you about the updated information regarding dentistry. To those people who did not see me on my previous episodes, my name is Ofelia Villanueva, practicing for almost 18 years in Quincy, Massachusetts. I graduated in the Philippines and also in Boston University, graduate of dentistry. Today, I have a guest speaker now, and he is a general dentist. And his name is Dr. John Pappas. Hi, welcome Dr. John Pappas. How are you doing?
Very good, Dr. Villanueva. Nice to see you.
Yeah.
Welcome to the office.
Yeah. Thank you so much for letting me to interview you, and so that you can help the viewers to understand the general dentistry. Dr. John Pappas is a general dentist.
Thank you. My pleasure.
Yeah. Can you tell me about your dental education and how long are you been practicing, and where is your office to? I know we are in Boston.
Well, the office is in Copley Square, and I went to Tufts Dental School down the street, actually, literally, and I've been practicing for 7 years now.
Oh, that's good. Yeah. As you know, I'm also a general dentist, but I cannot explain well because I have to interview Dr. John Pappas. And thank you again.
My pleasure. I'm sure you can answer the questions just as well as I can.
Okay, you know, it's not a question, but I want the viewers to know about general dentistry, or he's a general dentist, and what is he doing? Can you tell me?
Well, general dentistry, a general dentist can do everything that all the specialists can do. However, a lot of times it's a preference-based thing. Some general dentists love to do extractions or dabble in orthodontics or anything like that, or sometimes root canals. But essentially, you're almost like a point man, like you quarterback a patient's oral health. So you can refer somebody for wisdom tooth extraction, or if they need a root canal or an implant or orthodontics, they can go to a specialist. And it's almost like a setup in the same way as a primary care physician, except I think more things are done at the general dentist's office. You have your cleanings and your checkups and all the routine things like fillings and whatnot done at the office, no matter who you are. But general dentists dabble, and they can do whatever they want. They're licensed to do all the specialties of dentistry.
So meaning you are the gatekeeper. You know, the patients should see the general dentist first, and then you can refer the patient to the specialist if you have to.
If necessary.
If necessary. But if the dentist has a knowledge of course you have a knowledge of doing root canal, you can able to do that, right?
That's right.
And if you can do a simple extraction, how about the braces? Can general dentists do that too?
Yes, they can.
Oh, okay. If they have a fashion, is that fashion, or like if they want to do that, even though?
Is it fashionable to do it, or is it the new thing to do?
Yeah.
I would say that a lot of you want to go. In general, you would, if it's a difficult case, you'd want to go to an orthodontist. But as an example, if the dentist has advanced training in orthodontics, they can do that as well. They can do braces if they want to.
So that's good, you know. Can you tell me, okay, when the patients go to you, do an exam, the hygienist will clean the teeth, and then you'll see and evaluate, doing comprehensive examination, you see that they have a lot of cavities. Now you're going to tell them that they need a filling. And tell me, when do you indicate we call it tooth-colored filling or a white filling, and to the viewers, amalgam to us, or silver filling, and how do you explain that to the patient? What do you recommend to them?
Well, nowadays things have changed. The amalgam or silver fillings, like the viewers probably are familiar with, is something that's been around for probably over 50, 60 years. and they're not aesthetic anymore. So essentially, in this area, I don't do too many silver fillings for two reasons. One being not so important, but aesthetics for one reason, and another reason is because they tend to be mercury based. The silver fillings have mercury in them, and although the FDA does have it very recently just reaffirmed the safety of amalgam of silver fillings, at the same time it is medical waste. You have to have a special company come and remove scraps of it. You can't just throw it in the trash. So a lot of times we do composite resin-based tooth-colored fillings in all areas of the mouth, posterior, anterior, wherever they are. Typically, I usually do a composite resin tooth-colored filling.
Yeah. So, meaning you are doing mostly a white-colored filling?
Yeah. Yes.
Me as a general dentist, I do both.
Yes.
And explain to the patient, the amalgam or silver filling and the white filling. Because there's a history that amalgam filling really is, decayed, that it's very strong. So I gave the choice to the patient.
Yes.
I explained, I gave them the pamphlet, and you tell me what do you want me to do. Okay, so you answered about that one, the difference between the tooth-colored and the silver filling. I would like to ask you about the Invisalign.
Okay.
I cannot go through too much because I know last time on my episode with an orthodontist, I already asked that. But then that was like, I think, couple of weeks. So now, can you tell us about Invisalign?
Sure.
And who is qualified to do that? And how you're going to be qualified to do it?
Well, you have to be certified. Invisalign, first of all, is clear aligner therapy. It's a brand. It's just like, rollerblade versus roller skates. Rollerblade is a brand of inline skating. Invisalign is a brand of clear aligner therapy. So essentially you have to be certified in clear aligner therapy. And a lot of people qualify for it, but it's not exactly ideal for every orthodontic case. But it definitely works and has some really nice results for patients who do not want to get brackets, braces on their teeth. And
Okay,
wires.
so Invisalign, I don't do Invisalign. I let it to my orthodontist to do that. But I know any general dentist can do Invisalign, right?
So long
just
as
to
they're
be
certified.
certified. Okay, just Invisalign is to correct the malocclusion or bite or overlapping teeth. Is that
Crowding,
Crowding.
spacing, an overbite, overjet, which is the horizontal plane.
Yeah.
Those are all things that Invisalign is designed to correct.
Okay.
And Invisalign, again, is clear aligner therapy. It's really a clear tray that's designed to do it.
So actually, it's not a replacement of the orthodontic treatment with the wires on the mouth?
In a lot of cases it is, but it
okay.
can't do, in other words, the brackets and the braces and the wires, they can do almost everything. Invisalign can do some things. So not everybody is a great candidate for Invisalign, whereas for brackets and braces, you can put those on anybody.
Yeah. Okay, so I want to jump to another question because
Okay.
as I said, Invisalign, we mentioned that already with my orthodontist last time. So now I would like to ask you about the veneers, cosmetic dentistry. General dentists can do cosmetic. As I said, they can do all phases of treatment. You're allowed as a general dentist. All you have to do is certified and get a training, more training for that.
That's
So
right.
can you tell me about the veneers? And is that laminaires? Luminaires? Yeah, luminaires, I'm sorry.
Well, veneers are essentially, in a lot of ways, they're a prosthetic device. It's like half a crown, and it does a lot of different things to correct certain aesthetic elements of what a patient does not want to look like. So, in other words, if you have a space in front of you in the teeth that you want to get rid of, or there's some teeth that are crowded or discolored, a lot of staining or tetracycline staining, which a lot of patients have because when they were younger they had that antibiotic and it stained the teeth intrinsically, which whitening does not take care of, or something to that effect. Veneers do a tremendous job on that. Luminaires is a veneer, except it's a very minor procedure. Sometimes they call it prepless, but basically
Prepless means
prepless.
minimal invasive
That's right.
procedure.
A lot of
Yeah,
times you don't even need to anesthetize for that. However, lumineers are not indicated for everybody. As an
Okay.
example, you know, it's a very thin veneer. It's a very strong veneer, but it's a very thin veneer, about 3/10 to half a millimeter in thickness. So if
yeah,
you're heavily stained, it might not actually take care of the stain that you want to mask.
Yeah.
So as a result, it's not exactly indicated for everyone. In
Okay.
addition to, say somebody has like a really thin upper lip, well, you're adding some thickness to the existing teeth. If you don't reduce that, then they might look like they have buck teeth or something that looks a little odd. So then you're not accomplishing the goal aesthetically that you would want to get with lumineers. So in a lot of cases, people come in, patients ask about lumineers. However, they might not be qualified as a
Okay.
candidate because of different things.
Okay.
But veneers are a very good option, and lumineers are a very good option.
Yeah.
Both very strong.
Okay. Isn't it that if you're going to do a veneer, it's not only one tooth, right? To make it more cosmetic or aesthetic, you have to do at least 8 teeth.
I
You know-
wouldn't say it depends. It's a case to case. It's case dependent. However, a lot of times you don't want to single out one tooth, because I give the analogy to my patients all the time about if you have a brand new car, you know, about a year old, and you get into an accident and you just replace that fender. That color is not going to match, no matter
Okay.
if you bring it to the dealer or not. You know,
Okay.
it's going to
Oh,
be slightly
okay.
different.
All right.
So
Yeah.
a lot of patients, when they come in and they're very aesthetics conscious, in the end do multiple teeth because they don't want it to stick out. Because as it is, they want it to blend in or look whiter. And if you only do one, many times you don't accomplish that goal.
Okay, next I would like to ask you about the teeth whitening. Teeth whitening, can you differentiate the teeth whitening that they used in the house, that they can buy over the counter, and the one that the dentist is using? Because when the dentist do that, you know about the Zoom example,
Zoom, yeah.
okay? And I use Zoom, you know, but there's a latest one now without using lights, and the
Yes.
effect's still the same. But I would like you to differentiate the one that they can buy over the counter, like, you know, the paste on.
Okay. Well, basically, the over-the-counter whitening systems also work, but you do have to use a lot of it to get the desired result that a dentist would be able to get a little bit faster. So a lot of times if a patient asks me the differences, I say in the end that basically you get the same result, but you end up spending about the same and more time doing the over-the-counter, because you have to keep on buying that material to get to the desired shade that you want. Whereas if you came in the office,
Okay.
it would be a very quick thing.
Okay.
And then, of course, the take-home also has its advantages because it's all patient dependent, and they can do it on their own until they're happy with whatever shade they want. They can get it as white as my coat, or whatever they want.
Yeah, that's good. But isn't it, do you think that teeth whitening in the dental office is really 100% that they can whiten it?
Oh, I mean, basically, I would say that the system that I like, that I use, which does not have a light either, has been extremely effective, even on people who already have pretty white teeth and
Okay.
want to continue to get teeth that are whiter. So I've definitely seen a lot of good results.
Yeah, good result, but not 100%. Because even in myself, when I'm using it, I think depend on the pH of the patient too. Like, you know, the response of the, person. You know, some they have like really white, some they don't. And it takes long to have that. What is the reason?
I would say that might have to do with the absorptive quality around the teeth, how porous the enamel is that allow the teeth, the gel to soak into the tooth and whiten it. But to be quite honest, I haven't really had a negative result except on one patient who had a lot of tetracycline stain. And
Tetracycline
it
discoloration.
whitened everything, but it still showed the gradation, the difference in the shade that already existed. Everything raised up, but it was still
Yeah.
relative, so it was still darker in the darker areas.
Right. I think prolonged use of teeth whitening, because I read one research that even though you have a tetracycline discoloration, it will be whitened. But the thing is, it takes long, like a year. And I said, oh my God, a year? You know, but
That's a
anyway,
lot.
yeah, it's a lot. Okay, so we covered that teeth whitening. How about the temporomandibular disorder? Temporomandibular disorder, can you tell to the viewers, you know, what is that TMJ saying? Oh,
Well,
I have pain
TMJ is
on
not
my
to be
jaw.
TMJ is not to be confused with TMD.
Oh,
TMJ is your
TMD,
joint.
okay,
it's the
yeah, right,
temporomandibular
okay.
joint.
So
Temporomandibular
TMD.
disorder is a disorder with the chewing muscles around
Mm-hmm.
the jaw, or the jaw itself, that connects the area that connects your lower jaw to the base of your skull, and that's the disorder. A lot of things, a lot of problems associated with that, a lot of possible reasons as to why. Certain schools of thought are that the bite is off, and that's why people grind, or they get headaches that way. Sometimes migraines that a lot of women get in particular are associated with TMD, and it goes undiagnosed for a long time. But basically, TMD involves headaches, earaches, neck soreness, sore jaw. Sometimes you get limited opening of the jaw, and all these things play a major role in your everyday life without even noticing it. And essentially, the real thing that most cases are solved with is a regular night guard.
A regular
that
night
you can
guard.
have made at the office, at a general dentist's office. But basically, there's a lot of reasons why people grind, and it's up to the general dentist to sort of figure that out. Because
Yeah, I would like the viewer to know about you said grinding of the teeth at night versus the clicking on the TMJ. You know, there's a difference between the two, right? Because you
There
said
is.
recommending night guard.
yes.
Can you tell about that bruxism? You know, like when you sleep and you grind your teeth, do you need night guard or occlusal night guard? Or if you have a problem like TMD, is the night guard indicated also?
Most
Who is
cases-
doing that? I'm sorry.
Sorry.
I give you 3 questions right away. And who is allowed to do the treatment for TMD?
Well, there are temporomandibular disorder specialists that I definitely have sent many cases to, because it's more than a night guard can handle, or and they need more than that. So they need to see somebody for that specific condition when it's really, really bad. Because I've had many patients come to me who cannot sleep anymore because of that, or have constant neck ache. You know, you don't really realize it, but your jaw can play a major role in your posture. And if nobody's born perfect, unfortunately. So there's a lot of facial asymmetry that plays a role. So if one condyle of your jaw is higher than another, that makes your muscles clench down so they can get the teeth to contact. And as a result, that makes your shoulder go up a little bit, and sometimes that makes your hip move a little. So a lot of things actually play a role in the TMD. General dentists make night guards, and they do a pretty good job in most of the cases. It used to be considered that only stress-related issues were causing TMD, but that's not necessarily the case. More research indicates that it can even start from childbirth, the way that if a baby has a pacifier for too long, it adjusts the way they're supposed to, the way their jaws hit. So as a result, they can have a more of a narrow jaw, because of the pacifier is not really a natural, it's supposed to mimic a nipple, but it's not exactly the exact same physiology, same anatomy of the nipple. So sometimes that causes developmental issues. There's a lot of reasons why people have TMD.
Do you think the bad bite or malocclusion, on our dental term, which is the bad bite, will give you TMD problem?
Sure, because a lot of times when your bite is bad, or if you have a really deep bite, it pushes, it makes you grind your teeth because your muscles are in hyper mode, so to speak, where they're constantly trying to find a happy place and they can't.
Okay,
So you end up grinding to find that happy place.
So you said about the night guard. Is that the primary solution for TMD? Like how long you let the patient to wear that night guard before you finalize to refer them to a specialist?
Most cases, the night guard works, but some cases, patients chew through night guards very quickly, and sometimes they need to get an intervention in that way because basically, clearly the night guard's doing its job because they're wearing down the night guard and not their teeth, but still it's not blocking the symptoms of grinding. So sometimes they need the more extensive therapy for that.
Okay. You mentioned about sleep apnea. Did you?
Apnea.
Yeah, you know, when you're talking about the TMD, can you tell the viewers about sleep apnea and what is what do you recommend for them? You know, what will happen if you will not do anything about sleep apnea?
Sleep apnea is a big problem. It's a lot of people have it, unfortunately, and usually it's obstructive sleep apnea, which basically indicates that there's something blocking your airway and it's making you snore loudly, inability to sleep, you're sleepy during the day. Those are the typical symptoms. I have patients who will actively just fall asleep in the middle of, not necessarily a conversation, but they might be out socially and they'll fall asleep because they're just so tired, they cannot sleep well, and they will prop themselves up at maybe like a 30 to 45 degree angle so that they won't block their airway. Most patients go through the primary care physician first, where they tell them, geez, doc, I can't sleep at night, because they don't think it's necessarily associated with the jaws. And so they'll go to a sleep study, and essentially they'll try that oxygen mask where they've got this big oxygen mask on that forces oxygen down, because if you don't do something about sleep apnea, you can get brain damage because you're cutting off oxygen to your brain. So it's a big deal. And eventually, sometimes I've had a lot of success with sleep apnea devices. I don't know if you make any, Dr. Villanueva.
No, if they tell me about that problem, I'm not going into that, including the TMD problem. If they have a problem or symptoms, and then I tell them, I will refer you. I can tell them only exercise on the muscles, as what you said, the occlusal night guard, and I'll tell them, 6 months period. If you're not, if you're still complaining about that, you tell me, and then I refer you to the specialist who will do that. Because I feel that, the person who will treat you really has the knowledge of doing that.
Right.
And I told them that being a general dentist, I'm limited to that. So I refer my patient.
Well, sleep apnea and TMD are associated. But at the same time, a night guard is not going to deal with sleep apnea. There's a different device that I make sometimes, which basically makes the jaw stay forward to pull the tongue out of the way, and all the pharyngeal tissues, all the soft tissues. Some people actually, because they feel like that, where the tonsils used to be or whatever, that tissue is overgrown, they'll actually have surgery to limit that, to cut it a little bit, to free the space.
Are you talking about the tonsillectomy?
No. I'm actually talking about post-tonsillectomy as an adult. You can't really breathe too well at night, so they will actually go in with a laser and remove the tissue that way so that they can free the airway up. Sometimes it's tonsils, sometimes it's just natural tissue that should be there, but it might be too big. A lot of times they say that people that are overweight can be having a problem with sleep apnea because they've got a little bit more mass, but weight loss doesn't necessarily mean that you're solving sleep apnea.
Okay, so it's better, to be referred and to check about that sleep apnea problem, right?
In general, they'll come to me after the fact, but I'm not necessarily a sleep apnea specialist. I do make the device, and I have
device,
success.
Okay. Is that covered by the insurance?
I don't know.
Oh, okay, so we'll find it out, Okay, I would like to ask you about the implant versus the bridges. Now the latest technology, implant, it's proven that really it's very effective and long lasting,
Yes.
especially if you are using the really good brand. I want you to explain to the viewers, about when do you indicate the implant versus the bridges, especially if you have only one missing tooth. Okay.
Well, basically, bridges continue to be a great treatment tool to replace a missing tooth. However, an implant is a bionic tooth. It can't get decay. It can last for a really long time. You still should clean it, but essentially you have a bionic tooth that you can floss through. A bridge, for those people who might not know, involve 3 teeth. In other words, the tooth that's missing and the 2 teeth surrounding that space. Sometimes they're challenged to clean. I wouldn't say they're difficult to clean, but they're a challenge to clean. And basically an implant is very easy to clean. It's just like a tooth. And they don't really break too often. They've got a very high success rate in the 90s, 95%, 96%. So essentially it's replaced the bridge as the treatment mode, because a bridge is not that it's obsolete, but an implant has so many more positives than a bridge does at this point.
Only the problem, an implant is very expensive,
It is.
So even in my practice, I always indicate as ideal now is implant. And secondary, which is alternative treatment, is the fixed bridge. But I know that if you compute the difference, actually, implant is the best.
Without question, the implant is, although it can be more expensive than a 3-unit bridge, it's pretty close to the price of a 3-unit bridge, depending on the practice. I can't really quote that for sure, so don't quote me on that, Dr. V. But at the same time, if there's a difference, it's definitely worth it, because it's a bionic tooth. This doesn't involve, a lot of times you might be drilling on 2 teeth that have no fillings on them just to replace this one tooth. And the implant involves nothing with other teeth around it. It just involves going in and placing the implant and putting the crown on it. And it's got a great result. And you can floss it regular, and you don't really have to worry about it after it's in.
Okay, so you recommend really implant is an ideal treatment now, but depend also on the case, right?
Many times.
Many times, okay. What about dentures?
Dentures?
Especially like the complete upper and complete lower. Especially those old people, the gums receded too much that it's very difficult, to stay in the lower. The upper, you can stay in very good because of the vacuum or the suction on the palatal vault. But how about the lower? I heard that it's nice to put an implant also, helping that,
There's no question that implants help dentures. Your body's very economical, so basically the bone surrounds the teeth. If there's no teeth there, over time the bone's going to go away, because there's nothing to support.
Yeah.
So over time, if you have a denture, it starts to not fit so well, because the bone and the gums have receded a little bit, and it starts to get a little loose. So a great little thing that implants have also started to come in on is an implant retained denture, which is tremendous because the bone stays around the implant.
Okay.
A lot of times the dentures just snap into that.
Yeah, snap in means, they can remove the complete lower, even though they have an implant.
That's right.
Right? It's like, are you talking about mini implant?
Sometimes mini implants mini implants are good for patients who might have had dentures for 20 years and now their bone is reduced so much that they don't have a lot of bone for a regular sized implant. And so a specialist might place a mini implant, which does not require to be so deep. However, its retention is just as good, because as the literature shows, the ratio of bone depth doesn't play that much of a role with implants. They're really a tremendous asset to the dental profession.
Do you think also implant is usable in a partial denture?
Yes, absolutely. It's a great. That's even better in a lot of ways because partial dentures are also relying on other teeth. So as a result, when you bite down, the force of your bite, when a partial denture is wrapped around natural teeth, tends to loosen those teeth over time because they have this. You have a tremendous amount of force when you bite. So essentially, you're pulling those teeth eventually out. And implant retained partial dentures are great too because they also can snap in and they don't require the support of the other
Okay,
teeth.
so implant retained denture. Is
Yeah.
that what you call that? Instead of putting a clasp or like
Around
a
the
hold
tooth.
around the tooth,
Yep.
then you have an implant besides the natural tooth,
That's right.
and then the partial denture will snap in there.
That's right.
Okay.
And it works great. It's more economical because you're replacing multiple teeth, and at the same time you have a couple implants in there that snap it in, and you have a great result. And you can snap it
Okay.
out and clean it too.
I think the disadvantages of that is very expensive, huh?
It can be, but I'll tell you, it's definitely worth it
Yeah.
because you have your mind at ease.
Yeah, okay. I want to discuss about recession.
Okay.
You know, the recession, tell me about the recession when you brush your teeth, so you're indicating use soft toothbrushes.
Right.
And about that electric toothbrushes, you know, like if you have that abrasion on the neck and it's becoming so sensitive, so the patients will say, oh, it's very, very sensitive. I brush too much. So tell about, you know, the viewers about the recession.
Well, you know, nowadays I think if you walk into a drugstore, you probably won't really see differences in the hardness of brushes. It'll be soft or extra soft at this point. Back, you know, maybe 10 years ago, it used to say you could get a brush that would be hard, medium, soft. Nowadays, you can take the hard and medium brushes and use it to clean the tile grout in your bathroom or whatever. There's really no reason for it anymore when it comes to your teeth. So a lot of times you at this point, even with an electric toothbrush, as long as you're not pressing too hard, there should not really be any major cause of recession by what you're doing. Sometimes, though, that recession can go misdiagnosed, and essentially, a lot of times it has to do with, again, bruxism, TMD, because as you know, the enamel around the neck of the tooth is thinner than it is on the top, and you might see somebody who's wearing down their teeth on the top and also has the same wear around the neck of their tooth at the gum line.
When do you indicate the recession to have a filling? Let's say on the front teeth, if they have a gum recession, and actually you can see that, you know, the second part of the tooth, which is the dentin, is showing, and they are almost near to the nerve tissue.
Right.
Do you indicate them to do a white filling?
Yes,
Or
we
do you
usually
ignore it?
No, we usually do a bonded filling there, or we send them to the periodontist maybe to determine if they need a graft in that area. If it's possible, then they can have a graft instead of a bonding, because it's
Okay.
much more preferable to bring the tissue back up to where it's supposed to be,
Okay.
rather than put a little composite filling there that's going to be very aesthetic, but you didn't really take care of the recession issue. If you couldn't bring it up, it'd be much more preferable. But
Yeah.
either way, you don't want the tooth to wear down to the point of getting to the nerve of the tooth.
Right, yeah. So he's talking about grafting, you know, a soft tissue grafting. Like if you have a gum recession, especially if it's only localized, meaning 1 or 2 teeth, then instead of putting the filling on, then you indicate a grafting, like a soft tissue grafting,
That's
or
correct.
we call it connective tissue grafting
That's right.
in a dental term. You know, especially if you have a crown, and because you brush too much, and then it's showing the neckline, it's showing the metal, then you
Sometimes
indicate the
underneath it.
grafting, or you indicate to redo the crown.
Right, sometimes you have to redo the crown if that's the case, but at the same time, then that tooth might really look very long and not be the most aesthetic result that you want. So sometimes it's better to bring the gum back to where it belongs.
Okay, all
But
right.
that's only if it's possible. Sometimes the gum loss is associated with bone loss. The gum
Bone
follows
loss, yeah,
the bone.
okay,
So
yeah.
if the bone is
The
away,
bone follows, what did you
the
say?
gum follows
Okay,
the bone.
the gum, so the gum follows the bone.
That's right.
Okay,
in
so
other
I just
words,
want to
if-
tell the viewers about that
because
one, you know.
Basically, if you have a lowered bone level, then you'll have a lowered gum level.
Okay, all right.
This is an intraoral camera that we like to show patients as a diagnostic tool what's going on in their mouth, what we see, and many times in the posterior area, patients have no clue. You say, there's a crack on tooth number 15, and they have no idea what you're talking about. But this little camera here does a tremendous job of showing the patient on the computer screen, on the monitor, what is exactly going on and what exactly you see and why something needs to be done versus leaving it alone or whatever. It's a great little tool that I think every dentist should have. This is a veneer, an example of a veneer, all porcelain. With no metal underneath it, so it comes out as natural as it can possibly look and aesthetic as it can possibly be. And essentially, you can see on this side here, this is pretty much what a crown would look like on the same exact tooth on that side. A veneer is essentially half a crown. If I turn this around, you can see that the back side of the veneer, of the tooth itself, has not been touched. And very durable material, very long lasting. And a luminaire involves very little reduction, whereas this veneer, you can see, has about half of a crown reduction, half of a tooth reduction on it. And a luminaire typically has a minimal amount of reduction, if at all, and it has a great result if you qualify. If, in other words, there's if you're a good candidate, not if you qualify like for a loan or something like that, just that if you have the room for it and it's indicated, then we'd love to do it as a restorative dentist. This is a diode laser that is used by many dentists, many restorative dentists. There's a ton of things that you can do with a laser. Sometimes you can do a filling or a very minor invasive filling. However, this is a soft tissue laser. So in other words, a lot of times you want to contour the gums on an aesthetic case, like veneers or something to that effect. Or some people need a frenectomy when they have a big space in the front of in the two front teeth. There's a little muscle attachment of the lip that you can remove with a laser and is not as surgically involved as without using a laser, which usually involves a scalpel. As a result, the laser has a much more has a better effect when it comes to recovery. You really just get the patient numb. You remove the little freedom with the laser, and afterwards there's very little recourse. There's no soreness really associated with it, and so as a result, it's got a tremendous advantage over using a scalpel and then suturing the patient. And I use this typically for aesthetics cases, and frenectomies is what they call that, along with many times when you do crowns. This is a nice little tool to just isolate the area and dry it out. Also, hygienists can use this for deep scalings, and they can get down really deep and remove the tartar buildup that is very low. And also, again, it's less invasive. So a laser has tremendous advantages when used correctly.
All right. I think I have no more questions.
Nothing?
Maybe you can ask me. I don't know if I'm going to answer you. But anyway, Dr. John Pappas, I know this is a long interview. Mm-hmm. I interview a lot of people now, and they have their own specialty. But I think general dentistry has a lot to ask. And I think I cover everything today. And Dr. John Pappas, I appreciate so much of letting me to come to your office.
Oh, thank you. It was my pleasure.
Yeah, thank you so much,
Thank you.
And to the viewers, I have a next episode that I would like you to watch, because I'm going to interview an endodontist and maybe an oral surgeon. And have a nice day.